The next lecture is going to be AKI in renal and non-renal solid organ transplantation by Vincenzo Cantalupi.
Thanks for a kind introduction, and thanks to Ravi for inviting me to the Congress. So we start with renal transplantation. And I want to start with this slide from the hereditary registry, in which you can see the expected remaining lifetime with the red circles and what happens in dialysis patients in green and in transplant patients in violet. Without doubt, kidney transplantation represents nowadays the best therapeutic option for end-stage kidney disease patients. And if you look at this hypothetical model of time course of deterioration of kidney graft function, we can say that something occurred in the first phase of kidney transplantation. We know that in kidney transplant, delayed graft function, DGF, is something clinically important, and we have different risk factors for DGF that is defined as the need of dialysis in the first week after transplantation. We have some risk factors associated with the procurement, in particular called ischemia time, donor age, the use of marginal kidneys, and some other risk factor of the recipient. So basically, we can have the renal function of an ideal donor, of the marginal donor, but we have an increase of the progression towards CKD and return to dialysis. We know that kidney transplantation is a matter of time, so we have different times, including the declaration of death, in which AKI may be present in the donor, organ recovery, cold storage, and kidney transplant. Starting with the donors, so one of the questions here is if you have AKI in the donors of kidney transplant, are the concerns justified? So as you can see, we have, if the donor develop AKI during the ICU stay, we have an increased risk of DGF with an odds ratio of 2.2. However, transplant for donors with AKI versus no AKI, if you look at the outcomes, are not different in terms of length of hospital stay, estimated GFR, allograft survival, and acute rejection. And this is also present in this meta-analysis. If you look at the forest plot for eGFR in AKI versus non-AKI transplant from donors with kidney transplant, no difference in terms of eGFR, no difference in terms of acute rejection. Some concern arise from the Thai National Transplant Registry, in which you can see also in this case no difference in terms of patients and graft outcome in AKI versus no AKI, but if you consider persistent versus recovery AKI, you can see that persistent AKI in the donors may lead to an increased to a worse outcome and to an early deterioration of graft function, as you can see here, persistent versus complete or partial recovery of AKI, in particular for stage 3 AKI according to KDIGO. And so putting things together, we can have AKI in the donors and the development of DGF, but you can also have DGF for other causes. So AKI in the donors is a risk factor, but we have other risk factors to consider. And if you look at the survival of the kidney graft, the most important thing really is the presence of delayed graft function. These are data from our unit in which you can clearly see how the kidney graft survival in patients experience DGF is significantly lower than in the patients without DGF. So this is the most important cause of obviously of DGF is kidney ischemia reperfusion injury. Also because today we know that ischemia reperfusion injury can lead to the surface hidden antigen, leading to an increased risk of T-cell mediated rejection and antibody mediated rejection. That is surely the most important cause of chronic loss of kidney function. Today we have machine perfusion, and we clearly know from different studies that machine perfusion are able to decrease ischemia reperfusion injury and the risk of DGF. Also because this machine perfusion can support oxygen and nutrient, can have a role in the clearance of inflammatory mediators. So in Italy, we have studied cytosorb called Persorb in this system of machine perfusion to avoid tubular injury. So we have a potential vasoprotection and also some therapeutic interventions such as the addition of drugs to the system. And we have different studies clearly demonstrated that both hypothermic and normothermic machine perfusion leads to a protection of the kidney. These are some data from normothermic machine perfusion versus cold storage looking at RNA sequencing, and we can see the decrease of inflammatory gene expression related to inflammation and cellular damage. However, we can also have some AKI events, not only in the early, but also in the late phase of kidney transplant. And so we have different causes of AKI, including obviously immunological causes, such as T-cell and antibody-mediated rejection, drug toxicity, and infection, in particular viral infections, such as CMV and polyomavirus infection. And these are data from ICU in French in about 200 patients, in which you can see that AKI in kidney transplant patients is mainly due to sepsis and leads to the development of anti-HLA antibodies, so a risk for rejection. And this is another study from the US in which AKI is an independent risk factor for chronic kidney disease progression. So exactly what we observed in the native kidney is also present in transplant kidney, in which AKI is an accelerator of CKD progression. I go to the second part of my talk, and so what is the clinical relevance of AKI in non-renal solid organ transplantation? This is an old study showing chronic renal failure after transplantation of non-renal organ, in which drug toxicity is, in particular CNI toxicity, is the most important factor. However, we have probably an underestimation of the role of AKI in this setting, also because we should consider that we can have a patient with pre-existing chronic kidney disease undergoing non-renal solid organ transplantation, and AKI may worsen the clinical course immediately after transplantation, but also in the later phase, once again leading to the progression toward chronic kidney disease, the need of dialysis as a kidney transplantation. And one important thing is to really assess renal function before the transplantation and after AKI episodes. Our suggestion is to use some stress markers or some biomarkers, but in particular some stress tests such as renal functional reserve. This is the RFR and based on the proteinuria load developed by Claudio Ronco in Vicenza. And basically renal functional reserve may be defined as the difference between the peak and the baseline GFR. Higher is the renal functional reserve, lower is the risk for AKI and CKD progression. And this is a test that can be adopted in these frail patients. Also because if you consider what happens in non-transplanted patients, obviously we know that the AKI is a risk factor for CKD progression. But look at what happens in transplant patients, because we can have pre-transplant insults such as infection, drug toxicity, hypovolemia, end-stage organ failure. So the percentage of patients going toward end-stage renal disease is significantly increased in respect to non-transplanted patients. And so we can say that AKI in the peri-transplant period is a risk factor for all the non-renal solid organ transplant recipients. And we have also some specific risk factor if you look at liver, heart, or lung transplant. Let me run through some examples. This is AKI in heart transplant recipient, in which you can see that the development of AKI requiring renal replacement therapy is a risk factor for an increase in mortality and for the progression toward chronic kidney disease. And it seems that the high use of vasopressor inotransplant is associated with the development of AKI, and a cardiopulmonary bypass times less than 170 minutes. It seems to be protective for AKI. And basically, we can say that we deal with this distant organ dysfunction following AKI. For the heart, this is what we classify as type 3 cardiorenal syndrome, in which AKI may lead for different causes, such as electrolyte and acid-base imbalance, uremic toxic accumulation, the activation of the sympathetic SNS and RAX activation, but in particular to an inflammatory systemic reaction able to induce alteration of the heart function. And let me give an example of this. We have different mediators that can be identified in this detrimental crosstalk between the kidney and the heart, in particular the production of these uremic toxins produced by the gut, with an increased permeability on the gut. These protein-bound uremic toxins can have a role in distant organ dysfunction. And in particular, we know that indoxyl sulfate, epicresyl sulfate, that are present in the blood of AKI patients can lead to the downregulation of clotho. Clotho is one of the most important anti-aging factors. And this leads, as you can see, higher the levels of indoxyl sulfate, lower are the levels of clotho, and this is associated with left ventricular hypertrophy. And if you look to lung transplantation, we observe the observation is quite similar. AKI is associated with an increased risk of mortality, and in particular also staging with AKI-DIGO. You can see has stage 2, stage 3 AKI patients are more prone to have a worse outcome, and the same thing can also be observed for the progression toward chronic kidney disease. So after AKI, lung transplant patients are more prone to progress toward chronic kidney disease. As reported for the heart, also for the lung, this was a topic of the AKI 21 work group, in which different causes, such as, again, RAS activation, uremic salt retention, fluid overload, but in particular, the inflammatory response to AKI may lead to lung injury. And I want to show you this excellent paper by Mark Pokolsky here at the UC San Diego, in which he identified the presence of inflammation in the lung after experimental AKI, and this inflammation is due to the presence of mitochondrial DNA that is released by kidney cells and can reach the lung, inducing damage. Similar thing, and this is the last example, in liver transplantation, in which we have an overall high incidence of post-transplant AKI and severe AKI requiring renal replacement therapy. And AKI is also associated with graft failure, as you can see by this meta-analysis. Also in this case, the underlying etiology of liver disease may be different. For example, NAFLD seems to be more pronounced in patients. The AKI seems to be more pronounced in orthotopic liver transplant patients with NAFLD in comparison to alcohol-related liver disease. And also in this case, as I show you for the lung, renal ischemia reperfusion may lead to toll-like receptor 9 dependent release of mitochondrial DNA, and this DNA, mitochondrial DNA, is able to damage hepatocytes and macrophages, leading to inflammations in the graft, in the liver graft. So basically, it's something similar to what described by Midrab, in which AKI is able, through the release of uremic toxins, acid-base and electrolyte imbalance, inflammation, and oxidative stress, to lead to the dysfunction of different organs. But this is most important if you have a grafted organ, because you can have also some other causes of damage. These are my take-home points. First, AKI in kidney transplantation can lead to CKD progression with a premature loss of graft function, DGF, as well as AKI episode in each moment of kidney transplant life. And we also know the cellular mechanisms that are quite similar to non-transplanted kidneys in terms of fibrosis for capillary rarefaction and tubular epithelial cell senescence. AKI in non-renal solid organ transplant recipient is an independent factor associated with an increased risk of mortality and progression toward chronic kidney disease. We know that AKI is associated with distant organs, so graft dysfunction, and we also know some molecules that are involved in some mechanisms. Probably in the future, we need to improve patient selection for the use of renal functional reserve of biomarkers. And with this, thanks for your attention.